Hey everyone, and welcome to this high-yield medical explainer. If you're currently prepping for your boards, or honestly, if you just need a rock-solid, incredibly focused review of microbiology, you are in exactly the right place. Today, we're locking down one of the absolute highest-tested concepts in all of medicine, Streptococcus pneumonia. And specifically, we're going to figure out how to confidently distinguish it from viridin streptococcus. We're going to break this down into a really clear, logical structure, so these facts literally just stick in your brain for test day. So let's dive right in. Here is our game plan for today. First, we'll hit micro-ID and exam distinctions. Second, we'll look at the major clinical syndromes. Third, we'll cover treatments and resistance pathways. And finally, number 4, we'll wrap up with vaccines and high-risk groups. All right, part 1, micro-ID and exam distinctions. So here's your classic board showdown, S. pneumoniae versus viridin streptococci. Now, both of these bugs are alpha hemolytic gram-positive cocci. So when you get that clinical vignette, how do you actually tell them apart? Well, it essentially comes down to 2 major tests. S. pneumoniae is optokin sensitive, meaning its growth is completely inhibited by optokin. It is also biosoluble, which just means it lyses right open in the presence of bile. Oh, and it classically presents in pairs, diplococci. Now flip that around for viridin streptococci. They are optokin resistant, they are bile resistant, and they typically grow in these long chains instead of pairs. So your absolute golden rule here, sensitive and soluble equals S. pneumoniae. Let's zoom in a bit closer on those core traits for S. pneumo. You are going to see the phrase lancet-shaped gram-positive diplococci all the time. Honestly, if you read that description, your brain should immediately scream S. pneumo. We already mentioned it's alpha hemolytic, right? That shows up as this partial hemolysis producing a really distinct green color on blood agar. Another key differentiator is that it's catalase negative. This is absolutely crucial because it instantly separates it from staph species, which are catalase positive. And finally, whatever you do, do not forget the quelling reaction. When this encapsulated bacteria gets exposed to type-specific antisera, the capsule actually swells up under the microscope. It's totally an old-school test, but man, exam writers just love to test it. Moving right along to part 2, major clinical syndromes. Okay, so the most famous presentation, obviously, is pneumococcal pneumonia. Picture this clinical vignette. A patient has a super abrupt onset. We're talking sudden fever, shaking chills, and a nasty cough, producing this classic rust-colored sputum. If you look at their chest x-ray, you're looking for lobar consolidation, basically a dense opacity that just takes up an entire lobe of the lung. Now, while most of these patients are going to have a highly elevated white blood cell count, usually shooting up over 15,000, there is a massive board trap hiding here. If the vignette purposely describes leukopenia, a dangerous low white blood cell count, that is actually a critical poor prognostic sign that's highly associated with a fatal outcome. So watch out for that. And speaking of traps, let's talk about a really specific pediatric exam pearl, round pneumonia. If you get a question showing a kid with a perfectly spherical consolidation on their chest x-ray, do not freak out and immediately jump to a lung mass or a tumor. In children, this really unusual spherical presentation is highly associated with S. pneumoniae. It's a classic trick that constantly catches test takers off guard on imaging questions. But here's the thing, strep pneumonia doesn't just politely stay in the lungs. It's actually the #1 cause of bacterial meningitis in both adults and children today. It usually reaches the meninges through hematogenous spread, meaning it just catches a ride right through the bloodstream. And the stakes here are incredibly high. We are talking about a 20% mortality rate, and for the patients who do survive, up to half of them face severe, long-term complications. When you're sitting for your exams, keep your eyes peeled for the buzzword deafness or hearing loss popping up right after a severe headache and stiff neck. That is your textbook complication of pneumococcal meningitis. Let's pivot to part 3, treatments and resistance pathways. Listen up, because this right here is an absolutely massive board trap. Dexamethasone must be given before or with the first antibiotic dose. When you're treating pneumococcal meningitis, giving steroids definitely reduces mortality, and it prevents that severe hearing loss we literally just talked about. But timing is everything. If you administer the dexamethasone after the antibiotics have already started lysing the bacteria and triggering massive systemic inflammation, it provides 0 clinical benefit. None. Before or with the first dose. Lock that fact in right now. Okay, let's walk through this incredibly high-yield treatment algorithm for meningitis. Because we're dealing with high resistance rates, your initial empirical therapy, before you even know the sensitivities, has to be vancomycin combined with either ceftriaxone or cefotaxime. You absolutely have to cover all your bases up front. Then, once you get the lab results back, you can safely narrow it down. If it turns out to be penicillin susceptible, great. You drop the vanco and just use penicillin G. If it's penicillin resistant, but still susceptible to cephalosporins, you stick with ceftriaxone alone. And what if your patient has a severe beta-lactam allergy? You swap strategies entirely and go with vancomycin plus rifampin. This framework is pure gold for your studying. Speaking of resistance, how is this bug actually pulling it off? What's the mechanism? Well, S. pneumococcus becomes resistant to penicillin through altered penicillin-binding proteins, or PBBs. It basically borrows DNA from other strep species, creating these mosaic PBBs that just have a much lower affinity for penicillin. So the absolute must-know point here is it is not producing beta-lactamase. That's what Staph aureus does. S. pneumo is altering the target site itself. Also, as a really fascinating and somewhat comforting side note for actual clinical practice, true vancomycin resistance has not yet been clinically observed in S. pneumo. And finally, part 4, vaccines and high-risk groups. We've got two main players when it comes to pneumococcal vaccines, and understanding the core immunological difference between them is vital. First, we have PPSV23. This is your pure polysaccharide vaccine. Because it's literally just made of sugars, it only triggers a T-independent immune response. Now, that works just fine in healthy adults, but it is practically useless in kids under 2 years old because their B cells just can't process polysaccharides very well yet. On the flip side, we have the PCV conjugate vaccines, like PCV 13, 15, or 20. These cleverly link the polysaccharide to a protein carrier. That added protein effectively recruits T cells, turning it into a T-dependent response. This creates a robust, long-lasting B-cell memory response, even in tiny infants. And this leads us to a fascinating real-world public health phenomenon, the herd immunity effect. See, by vaccinating infants with that super strong conjugate PCV vaccine, we drastically reduce the sheer volume of bacteria colonizing their noses and throats. And since infants are essentially adorable little super spreaders, reducing their colonization directly cuts down transmission to adults. This indirectly protects totally unvaccinated adults across the entire population. But, nature abhors a vacuum. As we successfully eliminate those specific vaccine serotypes, non-vaccine strains start moving in to take their place. This is a concept known in the field as serotype replacement. So, considering all this, who is actually most at risk for getting severe disease? The absolute highest risk group, bar none, is patients with asplenia. That means either surgical removal of the spleen or functional asplenia, which is a classic hallmark of sickle cell disease. Your spleen is practically a giant filter that's essential for clearing encapsulated organisms like S. pneumo out of the blood. Without it, patients are at incredibly high risk for overwhelming post-splenectomy infection, which is horrifyingly fast and often fatal. Other high-risk groups include folks with HIV, the elderly, those with chronic lung disease, and notably, patients who just had a preceding influenza infection. The flu virus absolutely wrecks the mucociliary escalator in the lungs, making it incredibly easy for S. pneumo to just sneak right in and cause a massive secondary bacterial pneumonia. As we wrap this explainer up, I want to leave you with one final rapid-fire active recall challenge to make sure you're ready for test day. If you get a vignette describing an alpha hemolytic bug, but this time it is optocoin resistant, what major, life-threatening complication should you immediately be worried about? Think about it. I highly recommend you go look up the vital link between viridin streptococci and endocarditis. Keep that structured difference in mind, trust your preparation, and keep up the great studying.